Next, we are going to talk about blood administration. Here are your clinical objectives related to blood transfusions. Whole blood is blood in its original state. It is going to contain all the components of blood, such as white blood cells, red blood cells, plasma, and platelets. And whole blood is rarely ever used in the clinical setting outside of life-threatening hemorrhages, because most of the time patients do not need all the components of blood. And by giving them whole blood, we can increase the risk of a transfusion-associated circulatory overload, or TACO. So we are only going to use whole blood when it's indicated, and it's often indicated with patients who have had severe life-threatening hemorrhages because they have lost all of their blood products, and we need to ensure that we are appropriately replenishing them. More commonly, even in hemorrhages, you will see packed red blood cells given. And packed red blood cells are just red blood cells that are going to be packed in a small amount of plasma. And we use this for active and acute bleeding and to treat severe anemia. Another blood product that you may administer in the clinical setting is going to be FFP. And our plasma contains various proteins and clotting factors. So we are going to administer FFP when we want to replace those clotting factors, such as when a patient has had a hemorrhage, if they're in DIC, post-CABG or ECMO, and decompensated liver disease. Because with decompensated liver disease, all of our coagulation factors except 3, 4, and 8, it is 8, are synthesized in the liver. And liver patients are very prone to have episodes of bleeding and coagulopathies. And platelets are going to be used to treat things such as thrombocytopenia, DIC, and our cryoprecipitate is going to be used to replace lost or low fibrinogen due to bleeding, injury, procedure, or DIC. And cryoprecipitate is derived from our FFP. However, it is going to have a significantly higher amount of fibrinogen, and that's why we generally use that in situations where a patient may be having a low fibrinogen, like with DIC. And then you can have like the leukocyte depleted washed red blood cells, and that is going to be reserved to patients with history of a transfusion reaction or stem cell transplant. Generally, we do not replace red blood cells on a patient who is asymptomatic until their hemoglobin drops below 7. However, in patients who are being seen by cardiology who have just had stent placement, a myocardial infarction, or they have had orthopedic surgery, we generally are going to increase that threshold to about 8 grams a deciliter before we transfuse. Now, with your blood set up, it is important that you go ahead and get your Y tubing and your normal saline, and you go ahead and prime it and have all your clamps closed prior to your blood arriving to the unit, because remember, you only have a short period from when that blood gets there until you must hang it or return it back to the blood bank. Remember to use only normal saline. You don't want to use half normal saline
Think about that. That's going to cause more fluid to go into the blood cell, and it's going to cause lysis of the blood cells. You don't want to use lactated ringers because remember it has calcium in it, and that can actually bind to the citrate, causing clots in the blood. So remember, normal saline only, not half normal, not anything else. And you want to use an IV pump to administer the blood. There's a few situations in the ER and in ICU where you may not be required to use a pump, but the general understanding is to use a pump. Don't put anything else in the same line while the blood is infusing. And remember that Y tubing should always have a filter. It is important that you become familiar with the agency's blood transfusion policy because different hospitals may have different policies and procedures when it comes to administering blood. It could include things on albumin, whether you need consent for albumin. Some facilities require that while others don't. Here's an example of the blood administration policy from Cape Fear Valley regarding how fast we initiate transfusions under normal circumstances. For example, under normal circumstances, we're going to start the red blood cells at 30 milliliters per hour for that first 15 minutes. That is going to give us enough time to see if the patient is going to have a transfusion reaction while only putting minimal of that blood in there. And then you can increase the how fast the transfusion is going to 120 milliliters per hour.
Nursing considerations include reviewing labs. You want to ensure that the type and screen and the cross-match have been completed. You want to review their current hemoglobin. You want to ensure that consent has been verified. And you assess for any history of a transfusion reaction. You want to obtain the blood and inspect it for any type of discoloration, cloudiness. And you want to ensure that the blood that was delivered matches your patient's blood type or that it is O negative. You want to verify the blood product against the 2 patient identifiers. And you want to prime the blood tubing and begin the transfusion within 30 minutes of obtaining the blood. You want to obtain baseline vital signs prior to starting the transfusion, and you must stay with the patient for the first 15 minutes. But just because you only have to stay for 15 minutes does not mean that you still do not need to do follow-up assessments and monitor them very closely. And it's also important to provide client education. And remember, blood typing is going to determine the presence of A or B antigens. And when A and B antigens are both absent, a patient has O blood. You also need to monitor for if the patient has the Rh factor. And this is just an enzyme.
Remember, ultimately, always go to your facility policy. But in general, we're going to infuse packed red blood cells over 3 to 4 hours to prevent circulatory overload. We generally want to make sure that we have everything primed and set up so that we can start the transfusion within 30 minutes. You always remain with the patient for the first 15 minutes. And you make sure before you start the transfusion that you have a set of baseline vitals. And exactly on that 15-minute mark, you're going to get another set of vitals. You're going to provide patient education, and you're going to continue to monitor the vitals per facility policy. a transfusion, it is important that you discontinue the infusion and dispose of the bag and tubing according to your agency's policy. You want to assess for any type of transfusion reaction and for desired effects. For example, if my patient was hypotensive because they were in hypovolemic shock, we give them a unit of packed red blood cells. Now, my desired intention would be for them no longer to be hypotensive or for them to be less hypotensive than they were. You want to make sure you obtain vital signs and compare those with the baseline. And you want to document all aspects of the transfusion, including the volume, when it was started, your verification, and your patient's response.
You have various types of transfusion reactions. Many of them are going to be acute in nature, meaning they occur within the first 24 hours. And actually, most of these transfusion reactions are actually going to occur during the transfusion. These can include your acute hemolytic, your febrile non-hemolytic, your allergic, and your tacos. Now, you can actually have delayed hemolytic reactions, and those are going to occur after the first 24 hours. So those can be a little trickier to initially figure out because the reaction is delayed. Whereas with your acute hemolytic, hey, I'm infusing blood. Now suddenly I have the chills, fever, backache, tachycardia, and flushing. It's kind of obvious. With any type of transfusion reaction, aside from your taco, you are going to stop the infusion immediately. Taco is just transfusion associated circulatory overload. So you may have to stop the blood, or in many cases, you just need to slow down the transfusion. And this is going to be often seen with your packed red blood cells. That's why we try to give them pretty slow unless their condition warrants it. Other types of transfusion reactions can include a bacterial reaction, and that's going to occur when the blood is contaminated, and that's going to be very, very rare. And again, that would be more of a delayed reaction. You also have TRALIs, which is transfusion-related lung injuries. And when you have these are going to be immediate, and you want to stop the blood. You do not want to cause further injury to the lung. Now, the only time you don't stop the blood is with your taco, and that's when you may just need to slow it down. Any other time, immediately stop the blood, hang normal saline, you want to remove the blood tubing, and you want to send it to the blood bank for appropriate testing. Let me ask you this. Is a previous transfusion reaction an absolute contraindication to receiving a blood transfusion? Absolutely not. If a patient has a history of a transfusion reaction in the past or a history of receiving many blood products in the past, then the provider may pre-medicate the patient prior to the transfusion. For your mild to moderate transfusion reactions, you may give Benadryl and some Tylenol. Diuretics may be prescribed. Steroids, bronchodilators. Now, generally, if a patient has had a severe anaphylactic reaction in the past, we generally want to avoid giving blood products. This is where you need to look at your risks versus your benefits. If your hemoglobin is 2, you're probably going to want to give the blood. If your hemoglobin is 6.5, you just kind of want to hold out and do other things possibly, such as albumin, vitamin C, and other things to try to help with that anemia. So just use your critical thinking and clinical judgment here. In transfusing blood in critical patients, especially in trauma, the process may be very different. We may not have time for a type-in screen. If a patient is bleeding out, I don't have time to wait for the lab to get that compatibility. So we're going to start out with O negative blood. And then we're going to get that typing screen at the earliest able time. Also, we may not have consent. For example, if your patient is incapacitated and you can't get in touch with family, or you don't have time to get in touch with family, you can have two physicians consent. Because remember, you only have about 4 to 6 liters of blood, and if a patient is rapidly bleeding out, you're going to need to act fast.
This concludes your lecture related to blood administration.